Yes.
Can you see me? Because I cannot.
I can see you, doctor.
Sorry, I think
yeah, I start recording now.
A very good afternoon to all, and welcome to our weekly webinar session. Today will be our fourth and final webinar session for the month of nephrology. And our topic for today would be CKD, mineral bone disease. And here to enlighten us for this topic, we have with us Prof. Maisara, consultant nephrologist from University Malaya Medical Center. And our chairperson for today will be Dr. Liu Yufeng, consultant nephrologist from Hospital Pulau Pinang. Over to you, Dr. Liu.
Hello, thank you. Thank you, Dr. Narisha, for the introduction. First of all, I would like to thank the College of Physicians for inviting me and for also organizing this series of nephrology webinar. As you mentioned, that today's topic is on CKD and BD, which is a very important and common complications in our chronic kidney disease patients. So it's my pleasure to introduce our speaker, Prof. Maisara bin Jalalun Wahaili from UMMC, who has been very active in various studies in nephrology, has many publications to her name, and many of which are ISN index. Now I will pass the screen to Prof. Maisara to start the talk.
Thank you, Dr. Liu, for the kind introductions. Thank you, Dr. Narisha, and thank you, College of Physicians Malaysia, for inviting me today. It's a very great pleasure to talk with you all, share some knowledge in nephrology. So the topic given to me today is CKD and BD. What Dr. Liu mentioned is very important complications in fact, CKD patients. Overview of parathyroidism, long-term complications, pathophysiology, and management. So as I can highlight it here in front of you all, I'm sure each one of you has been seen many end-stage patients with complications. As you can see from this chart, this is a very familiar chart. The numbers of end-stage in Indonesia is rising trend, which is in 2008, which only about 4,000 plus patients, and now it's become 8,500 patients. But that back in 2018, it's been projected that the number is higher, in fact, in 2040. But out of these patients, not many patients get transplanted. So you know that these patients are prone to get all sort of complications of end-stage kidney disease. You have a webinar series already. And one of the complications that we're going to highlight today is CKD and BD. So once patients is at CKD5 or nearly end stage, we will start discussing about mode of renal replacement therapy. Obviously, transplantation is the best renal replacement therapy, and with transplantations, as if that you get a new native kidney, original kidney with a perfect functions, so that you can avoid all these kind of complications. But unfortunately, like mentioned earlier, the rate is pretty low. That's the reason why most of our patients need to go through hemodialysis, peritoneal dialysis, and some, of course, we kind of talk about conservative management because of various factors or reason that eligible them in order to do dialysis. So in regards to hyperparathyroidism, yeah, all of audience here, I'm sure that you guys are very good on this already and you have heard about all this. So we can classify it between is either hypo or hyper, but what commonly seen in CKD and BD is hyperparathyroidism. Of course, it's primary because of the hyperplasia, is increase in PTH and leading to the other consequences, while in CKD and BD, most of the time towards advanced CKD, or in fact, you can see in stage 4, 5 CKD, patient will have the secondary hyperparathyroidism because of hypocalcemia that trigger increase in parathyroid hormone. Of course, the other things, after some times on dialysis, this parathyroid gland become automatically secrete the PTH and ignoring the negative feedback of high calcium that's leading to the tertiary hyperparathyroidism. So that's what the renal hyperparathyroidism is. So like I mentioned earlier, the renal hyperpara, it can be secondary or tertiary. Of course, at the beginning or advanced CKD or in stage kidney disease, you see most of patients, in fact, majority of the patients are secondary hyperparathyroidism, because this is due to the hypocalcemia, increase in phosphate retentions, and a reduce in activated vitamin D synthesis. So that's the reason why parathyroid gland become hyperplasia and increase in parathyroid hormone. While in tertiary, usually we've seen this kind of scenario after the patient's on kind of dialysis for numbers of years. Then you see, despite having high calcium, the PTH is continuously rising, meaning that the PTH continuously secrete this hormone and ignoring the negative feedback of high calcium already. So this is kind of a very huge problem in dialysis patients, and it's lead to hypercalcemia, phosphate retention, and of course, they have this reduced activated vitamin D. So this is what happened. So originally it's low calcium in the blood and release parathyroid hormone and affect your bone because want to stabilize the serum calcium. And of course, it's decreased loss in urine to maintain your calcium as well. So this activated vitamin D is very important because it's enhanced the absorption of calcium from intestine. So you can see this is stimulate PTH, this is activated vitamin D, this is reabsorption of calcium. So, and then another thing is fibroblast growth factor, of which that it's been triggered by increase in phosphate. So this is secreted by your bone. So another diagram just to highlight the important in chronic kidney disease is reduced renal phosphate clearance, and it leads to hyperphosphate, and because increase in phosphate it trigger FGF23. So this will reduce vitamin D, it leads to hypocalcemia and eventually secondary hyperparathyroidism as well. So generally what you need to remember is that low in calcium, high in phosphate trigger this parathyroid hormone. That's the basic principle of pathophysiology in secondary hyperparathyroidism. And how this parathyroid hormone behaving. So initially, this is at the beginning of stages, which is at stage 5 or in fact earlier stages of end-stage kidney disease, meaning that just started on dialysis, a few months on dialysis, patient will be having this low calcium, high phosphate, and low activated vitamin D. At that time, the gland is still normal, so it's proliferates with time and eventually become hyperplasia and nodular gland. Okay. So what is the minispeciation? This is very important for us because sometimes patients presented with us basically with just very kind of non-specific complaint of body ache, okay, body pain, and in fact some patients presented with ulcer. Sometimes this get confused. Of course, the location will be different, but in CUA, they can present with ulcer, and this is not being treated aggressively, and this will be getting worse and in fact associated with high mortality. So the manifestation is either renal, what we call it renal osteodystrophy, dysregulations of mineral metabolism in CKD, which is can be presented with osteomalacia, adenoid bone disease, or before this we know also as brown tumors, the third one, a cardiovascular disease because of increase in calcium as well as increase in phosphate, this leading to media calcification, and this is a very bad outcome in regards to the cardiovascular outcome. Okay, and finally is calciflexis, and of course the tumoral calcinosis, which is this calcium tend to deposit outside your vessel, is at the tissue level, and this calcium depositions and become calcinosis. Yeah. So this what I would like to highlight. You can see here renal osteodystrophy, okay, over here, and also this all is just a classification, what we call it tumoral calcinosis. This is towards the end already, but what I would like to highlight over here, we may see some patient may presented to our clinic or our patients just with a very non-specific necrotic patch. Yeah. So if you take further history and ask this patient, if this patient has been on dialysis and you're interested to look at the calcium, phosphate, ALP, and IPTH, okay, because ALP indicate the bone turnover. Most of the time patient will have high ALP level, indicate that high bone turnover, and it's not a good prognosis because it's predisposed patients with a fracture as well. So with this parameter, for example, if this patient has very high calcium, high phosphate, high ALP, and elevated IPTH, of course, you need to suspect this lesion related to calciflexis or CUA. So I think this is very important to highlight because it's occur at non-pressure area. Okay, it's painful, and this can be progressive with a kind of non-healing wound. Okay, it's one of the differential of non-healing wound. This happened because the small vessel, which is your arterioles, lacking its perfusion, so tissue become underperfused, so it's become necrotic patch over here. You see this patient's ankle. You can see this necrotic patch, which is not nicely to be seen, but this is not a diabetic foot ulcer, things like that. Yeah, this has happened because of reduce in blood flow to the tissue. So this can be worsened further. So this is a very bad complications of CKD in MBD. We need to recognize it because once we recognize it, of course, we need to take further action. For example, parathyroidectomy. Yeah. So this is when it become worse. So it's very bad shape already. So it's it's become infected, and it's usually it's difficult to treat and lead to reduce in survival and high in mortality. Okay, this one you can see just a classification. You see this is a lung marking. It's a lot of nodular thing here. So actually it's a classifications similarly, okay, over the vessel of the limbs. So like I mentioned earlier, what are the complications of CKD? So it leads to cardiovascular, bone disease, and calciflexis. Why cardiovascular? Of course, number one, CKD patient or advanced CKD or end-stage renal disease patients, they shed a traditional risk factor of diabetes, hypertension, and dyslipidemia. All this going to cause the plaque, okay, within the intima layer. While another problem is the plaque in the media layer. Intima media is your layer of blood vessel, and all this calcium and phosphate deposited disease. Furthermore, this calcium and phosphate can deposit in the valve as well, and your FGF23 actually leads to myocardial dysfunction. So the next is bone disease. Of course, when you have high bone turnover, less calcium and phosphate in the bone itself, your bone become fragile, and patients can present to you with fracture, okay, low trauma fracture. So if you are seeing the end-stage patient or CKD patients come to you with fracture, you really need to kind of asking further in regards to this problem, because eventually if this fracture due to the CKD MBD, then of course the treatment of choice is parathyroidectomy. And finally is calciflexis. So how you make the diagnosis. So it totally depends on the stages of CKD. And of course, you are looking at the PTH, of which you check it, okay, at this interval. Is more frequently in stage 5 and dialysis patients. You measure the calcium and you measure the phosphate as well. Of course, our target PTH is basically 2 to 9 times of the upper normal limit. So usually when we start treatment, if the PTH more than 45 or 50, then we start treatment with vitamin D in order to bring down this parathyroid hormone. So I have shown you or highlighted to you kind of the complications in CKD MBD and how it's happened, and eventually how you manage this group of patients. Of course, this patient will be seen by Dr. Liu, the nephrologist in charge of center, usually the nephrologist in charge of center if this patient on hemodialysis. But if this patient is on peritoneal dialysis, of course, it will be seen by nephrologist at that specific hospital. And how we manage this patient as actually what important things to be highlighted with this patient is dietary phosphate. So it's very important to highlight to them. Nowadays, we have many sources of high phosphate diet, especially our fast food or processed food. So the patients need to be highlighted. All this kind of food, they need to cut down in terms of the intake. Okay, why is it so? because why the phosphate become high in our patients, because when there is loss of kidney function or impaired in renal excretion of phosphates, that lead to high phosphate. Of course, dietary phosphate absorptions is still continue, and at the same time, bone resorption release the store of phosphate. So all this accumulated intravascularly. So how you manage these patients? Of course, you has been started this patient on hemodialysis, and hoping that the phosphate, we can bring down the phosphate. But believe me, with hemodialysis alone, the removal of phosphate is very low. Okay, dialysis removal not sufficient enough to reach the target. So basically the intake definitely more than whatever you remove. So that's the reason why we need to change in terms of their diet by reducing the intake of phosphate or phosphate additive. Of course, it's a little bit tricky because we always advise the patients kind of to take high protein diet, but at the same time, this high protein diet is associated with high phosphate as well. And eventually what we want them to take is basically to take this phosphate binder. I will talk about this phosphate binder later, okay? And this phosphate binder reduce in phosphate absorptions, but of course some of the phosphate binder has GI side effect, and if you ask the patient to take a calcium pill 5 tablets 3 times a day, so obviously the compliance will be a big headache. Okay, finally, with the bone issue, of course you need to suppress the parathyroid hormone, yeah, by giving this calciummimetics, okay, or vitamin D to suppress your parathyroid hormone. Okay, so what I would like to highlight here, this is with conventional dialysis, yeah, 4 hours 3 times a week. So this is the phosphate removal, about 1,800 to 3,600 milligram per week. Okay, but you can see if these patients take a Western diet, yeah, so the absorption about 800 milligram kind of per day or per meal. So you can see this is obviously not enough. With PD is even lower, and of course it's higher with nocturnal dialysis because the longest hours of dialysis, and with short dialysis is become less removal. Okay, so this is to highlight that dialysis alone, even though you see end-stage patients, you see the high phosphate, you say, never mind, this patient will go on dialysis will remove this phosphate. No, eventually it's not really, because it's not enough as compared to whatever in the patients plus the output. So it's not balanced, yeah. Yes, number one, the key principle in managing the CKD and BD still a low phosphate diet. So what's contained phosphate is protein-rich food, the meat and the milk, phosphorus additive, the processed meat, the cheese. You can see what I highlighted here. So it's a lot of food contain phosphate. So if eventually what we need to do in fact, almost all of our patients need to be on phosphate binder. So when you see this kind of patient, especially the end-stage patient, you can see it's a lot of pills that are on. So further history in regards to the compliance is very important in order to manage this. These are the amount of phosphate binder. We give lanthanum. Lanthanum acesulfame is very expensive. So commonly or traditionally, the one that we give is calcium carbonate. Yeah, this calcium carbonate as a phosphate binder, we advise the patient to take with food. So it totally depends, because some center, I believe the calcium come in the capsule form, and some basically in the tablet form. If they are on tablet form, what we advise the patient is to chew this calcium together with the food. As well as if they are on capsule, usually they open up the capsule, put in the food, and that's act as a phosphate binder. Why we are not routinely give lanthanum acesulfame? Because of the cost. It's very expensive. Not everyone can afford it, but of course that's the best options, because eventually we want a balance between calcium and phosphate in the blood, so that we are not kind of over prescribed in terms of the calcium or increase the calcium store. So this is what kind of the type of calcium that we have that commonly being prescribed is calcium carbonate. So this is based on Malaysian CKD MBD CPG guideline. So as you can see here, the commonly give is calcium carbonate because it's low cost. Okay, but the side effect or the implication, it can give rise to elevated in serum calcium. We don't want that to happen as well. What is the target calcium among our dialysis patients? Actually, kind of lowish to normal. We didn't aim for high calcium in our dialysis patients because we know that that gives rise into possible vascular calcifications. So obviously the ideal is either cevimeline because this is a non-calcium based phosphate binder, or lanthanum is not give rise to vascular calcifications, but this is predisposed to the GI side effects. It is been seen, but it's not kind of commonly seen. You might have a patient that just started with cevimeline but come and see you because feeling abdominal discomfort, things like that. So it might be one of the reasons why this patient is having that. So another, this is not really new, but perhaps it's quite new in Malaysia in regards to give this sulfuric or C hydroxide in hemodialysis patients, and it seems to be effective as well and work as a phosphate binder. And you can see what I'm trying to highlight over here is that the difference between the non-calcium based phosphate binder and the calcium phosphate binder, you can see the straight line over here is calcium carbonate, and the dot line is basically the cevimeline, which is non-calcium based phosphate binder. They randomized this patient to look at the all-cause of mortality. So as you can see here, is higher rate kind of mortality is among the patient that are receiving calcium carbonate as compared to cevimeline. Similarly, in regards to the cardiovascular event as well, cevimeline treated patient experienced lower cardiovascular mortality due to cardiac arrhythmia compared to patients treated with calcium carbonate. So next, I've mentioned regarding the phosphate binder by using the calcium or non-calcium based phosphate binder. That's the reason why sometimes you see all these dialysis patients, they're on so many tablets. So this is one of the important medications that we need to check. Another thing is vitamin D therapy. Vitamin D replacement has been shown to be effectively suppress the PTH. Remember, our aim is to suppress the PTH so that there is a reduce in bone resorptions. So what are the vitamin D we give to this particular patient is usually the activated vitamin D, calcitriol, or 1-alpha. Observational study did suggest that there is improved in survival in patients treated with vitamin D analog. However, in meta-analysis, it showed no difference in mortality, bone pain, vascular disease, or rate of parathyroidectomy when comparing patients on vitamin D analog versus not taking vitamin D. But we still believe that at least this vitamin D did improve in terms of the parathyroid hormone, and hopefully to a certain extent is translated into a better outcome. So basically, this is your paracalcitol. What's important is you want to suppress the PTH hormone so that it's improved in terms of too much bone resorptions and fibrosis, bone remodeling and mineralizations. So at the same time, it acts as a renal and cardioprotective as well by decreasing all these pathways. Okay. So this is one of the trial, this the promo trial. Of course, this pericalcitol or vitamin D did lead to significant reduction in parathyroid hormone, which is good, right? The primary hypothesis of this study that paracalcitol will reduce left ventricular mass, okay, over a 48 months interval. This paracalcitol, like has been shown in this chart above, this graph have shown nicely decreasing in the sense of parathyroid hormone within 6 weeks after the initiations, and the level were maintained. But at 48 weeks, the change in left ventricular mass index does not differ between the group. Okay, episode of hypocalcemia were more frequent in paracalcitol, which this is common sense, right? You give activated vitamin D, it's increase in calcium reabsorptions from your gut. That's the reason why it's leading to higher calcium level or hypercalcemia. That's why it's very challenging in managing this patient, especially if they reach the state of tertiary hyperparathyroidism. This is because of in the tertiary hyperparathyroidism, the patients already have this elevated calcium, and at the same time, you want to bring down the parathyroid hormone, you give activated vitamin D. What this activated vitamin D lead to increase in calcium reabsorptions. So that's the reason why eventually the net effect is hypercalcemia. This is another study, the OPERA trial, show that they randomize the patients, okay? This is the patient with stage 3 to 5 with LVH and high parathyroid hormone. It's either paracetamol or placebo. Similarly, they try to look at the heart outcome. Okay, they give 52 weeks treatment of oral paracetamol significantly. Okay, this is similar like previous study show that it's increase in your parathyroid reductions of the parathyroid hormone. Okay, you can see here the straight line is paracetamol arm. Okay, the dot one is the placebo. There is a reduction in your parathyroid hormone. Unfortunately, it's not translated into the heart outcome as well. So definitely there are a lot of barriers in achieving control, and it's very difficult to manage the CKD MBD. That's the reason why the complication that I've mentioned earlier, the one that we worried of is calciflexis, is heart problem. That's the reason why CKD patients are at risk of cardiovascular disease. Sorry. And as well as bony problem, fracture, commonly seen among them. So a barrier in achieving this is definitely they are not get removed completely by dialysis. The effect of binder still not really great. Of course, the vitamin D adherence of patient is another problem, and this is a common problem. You give a lot of pill to the patient, is pill burden. Okay. Finally, the other treatment that available for this group of patients is cinacalcet. This is calciummimetic. It's basically modulations of the calcium receptor on the parathyroid gland. It's increasing sensitivity to extracellular calcium, thereby suppress the PTH secretions. Calciummimetic also known best as a medical parathyroidectomy. So obviously, if the patient has indication for parathyroidectomy, then the patient should go for parathyroidectomy. But if the patient just have a tertiary hyperparathyroidism without any history of fracture, there is no pruritus, there is no indications for parathyroidectomy, then perhaps a trial of cinacalcet is meaningful because it can avoid the patient to undergo a surgical operations. However, this calciummimetic or cinacalcet is very expensive. I'm not sure how about Dr. Liu, but me myself find it very difficult to start because in Ministry of Education, money is always a problem. It's not all the patients can afford this cinacalcet or calciummimetic. Of course, we love to start one, but of course, financially it's not allowable. Okay. So you can see this cinacalcet lowering down the PTH, and at the same time, you also bring down the calcium level. As contrast with your vitamin D, is increase the calcium level. In cinacalcet, is bring down your calcium level. So this is a study to show that among these patients, they randomized between either cinacalcet or placebo. And in this setting, they found that the rate of hypocalcemia is higher among the cinacalcet group as compared to the placebo arm. Of course, be careful, okay? Because whenever the patient is had this tertiary hyperparathyroidism already, most of the nephrologists will use calcium, low calcium bath, dialysate, and they kind of prescribe this patient with non-calcium based for binder and stop the kind of activated vitamin D or calcitriol, your 1-alpha has been stopped because this patient has high calcium. At the same time, you try to start this cinacalcet, okay? So end up this patient, we come to you with hypocalcemia, then you need to manage the hypocalcemia. So what I did is, because to be more effective, some say that it's good in combined cinacalcet as well as the activated vitamin D, in combination. Fully the suppression of PTH is greater and eventually lead to a better outcome, and it save cost as well. At the same time, you want to normalize the calcium. You don't want to bring down the calcium too much and patient end up with hypocalcemia. So if you see patient with hypocalcemia, another reason is because they are on treatment of cinacalcet. So I mentioned this just now. So this this is the first chart that I showed to you. This is what initially happened, and eventually it's become monoclonal proliferations, and finally it's end up with hypercalcemia, hyperphosphatemia, and hyperthyroidism or tertiary hyperparathyroidism. So the vitamin D, but severity much aspect to oral vitamin D is preferred Hi, can you all hear me?
Yes.
Yeah, I'm sorry, I think I was disconnected. Okay, so I move on, yeah. Towards the extreme, so I've highlighted this just now. This is kind of what will happen in your parathyroid gland and how the management of this take into places. I have explained to you in regards to dietary, the phosphate binder, and oral vitamin D. And eventually, when it's become very bad to control and difficult to control, and furthermore, this calciummimetic is leading to higher costs, and that is the time that you need to refer the patients for parathyroidectomy. Okay. So these are the indications for considerations of parathyroidectomy. Basically, you fail medical therapy, as well as the hypercalcemia, hypophosphatemia, which is unable to control and is persistent. Of course, your calciflexis with documented elevated PTH, your bone pathology, especially when the patient has fracture, and some patients just come to us with varicose, bony pain, and severe calcification. I've seen some of the transplant patients because on even though I've said that potentially transplantation will reverse the incidence of hypercalcemia, the parathyroid. However, this is important to evaluate case by case, because if these patients on hemodialysis for certain period of time, for a longer durations, eventually towards a certain extent, this cannot be reversed. And after 1 year post-transplantation as well, patient can end up with high calcium as well as highish parathyroid, and some of the patient complain of bony pain still. So what we advise the patient still to go for parathyroidectomy. So when to consider parathyroidectomy, this is based on our guideline. It's persistent elevated of PTH despite maximum medical therapy, refractory hypercalcemia or hypophosphatemia, high risk of calciflexis. Of course, another thing is a problem with CKD and BD is because of when you have too high parathyroid hormone, even though you give adequate amount of erythropoietin, you will kind of very minimal response, what we call it EPO hyporesponsiveness. So this is kind of surgical referral to parathyroidectomy. And obviously, if this patient been having this tertiary hyperparathyroidism for a long period of time, these patients can end up with what we call it hungry bone. This is a phenomenon when this patient has high bone turnover. Suddenly you shut down everything, you remove the kind of parathyroid gland, you have operated, patient will end up with severe hypocalcemia after the operations. So whenever we refer patients for total parathyroidectomy, it can be done total parathyroidectomy alone, which is everything get removed, all the 4 glands are removed, or with auto transplant, we keep 1 gland just because of we don't want the calcium lowered down too much until it's difficult to manage, and patients sometimes become so symptomatic for hypocalcemia. So this is something that patient might come to emergency with severe hypocalcemia post-operation. We need to correct the calcium aggressively because patient has no more mechanism to stabilize the calcium in the body. And of course, in these particular patients, there will be lifelong calcium and vitamin D. But parathyroidectomy can improve the symptoms, bone pain, arthralgia, the weakness, and of course, there is some risk of your laryngeal nerve problem and hematoma. So this is why I've said hungry bone because of hypocalcemia is the bone will
Hello, Prof. While awaiting for Prof to join us again, any questions from the floor? Norisha, can you contact her?
Yeah, I'm trying to. we apologize for the technical issues. Just hold on for a little while longer while we try to reconnect with Prof. Maisara.
Hi, so sorry. I will share my slide again. You can hear me, right, Noraisha?
Yes.
Yeah, we can hear you.
Yes. Yes.
Some technical difficulties. My internet suddenly become problem. Okay, so what I would like to highlight is just I have few more slides to go before I end this. So yeah, so the reason why I'm highlighted this is that one of us might see patients come to emergency department with severe hypocalcemia. Yeah, so that's the reason why I'm highlighted this hungry bone syndrome. So basically, it's happened with younger age group, high body weight, high preoperative alkaline phosphatase, because that's indicate your bone turnover, lower preoperative serum calcium and lower postoperative serum calcium as well. So this is kind of the risk factor to have that. So what KDIGO have seen? KDIGO said if this patient CKD 3, 5, the treatment should be based on serial assessment. Okay, so we are not based on just one reading and we give a phosphate binder because they are not on dialysis yet. We see the serial, only then we decided whether we should give this phosphate binder for this particular patients. So this is the old one. Yeah, you can see this is the old one. Okay, but the new one is based on the serial and try to bring down the phosphate. If you see serially, it towards upwards trend rather than just based on one reading. So this is to maintain or lowering PTH. Same thing if this patient's not on dialysis as yet. So obviously we monitor the level. But if it's not, if on dialysis ready, definitely you would like to bring it down. This concept is basically just to try to get balance between too much calcium being given to the patients and of course the balance if you're not suppressing enough the PTH. So this is we have this Malaysian CKD MBD guidelines in regards to the parathyroidectomy and SOP in order to manage them. I think that's all from me. So a few keywords that I would like to highlight is that the recognitions of the patients with very bad parathyroid problem because they end up landed with ulcers, of which that we always mistakenly or misdiagnose it. And number two, all this leading to high cardiovascular morbidity and mortality. And number three, of course, they can come and present it to you with a just fracture. Then as a general physician, we receive a referral. So all these parameters, the one that important we need to look at is the PTH, the calcium, the phosphate, and alkaline phosphatase. So with that, thank you. I open up the floor for any questions.
Thank you, Prof, for the excellent and comprehensive lecture. So far, I think nobody mentioned any in the chat box. I don't see any questions.
So, Dr. Yu, can I ask you, what is your kind of experience? Do you have difficulty to prescribe Sinacalcet? I do have because of the cost.
Yeah, I think we should highlight how expensive it is. Depends on where we purchase it. It can vary from about 17 to 20 ringgit for one tablet.
It is, yeah.
Yeah. So I do agree that we use, but we also combine with
vitamin D.
Vitamin D.
Yes.
Yeah. So this combination we find that very effective and more cost effective.
Yeah. But still, per tablet is 20 ringgit. majority of the patients cannot afford it. So that's
Yeah.
a sad thing because of it's difficult to get subsidized, especially myself, Dr. Liu, because I'm practicing in the Ministry of Education. Of course, our subsidy rate is different, and most of the patients still need to buy for it. So that's why we find it challenging. In fact, for the audience to know, we always prescribe just a 25 milligram, which is a very little tiny dose. This is very little as compared to what a Caucasian has prescribed in order to treat the parathyroid.
I think, yeah, they mentioned as high as 75 milligram a day.
Yeah,
That will come to 3 tablets.
exactly. And we just
Yeah.
paid 5, that's also we cannot afford it. So I
Mm.
think it's a lot of work if a college physician can help in terms of funding, things like that. So it's a lot of work need to be done in this field. And a lot of our patients end up with mortality and morbidity because of this CKD and BD, and eventually patient has heart problem and death because of, we always blame on the acute coronary syndrome or cardiovascular disease. Yeah.
Yeah, actually, renal failure, end-stage patients are really expensive disease.
Exactly.
Not only the dialysis treatment, the erythropoietin, also the CKD management is
Exactly.
very, very expensive.
Yeah.
Yeah, say it, bro. Save money in a hypothetical situation.
Exactly.
Save money is not an issue.
True. Yeah,
Hypothetical.
You are right.
What would phosphate binders would have? Let's say, would your phosphate binder of choice?
For me, of course, still money is a problem. Like you mentioned just now, it's about 17 to 20 ringgit calciflexis. I would like to give Sevelamer, it's about 6 ringgit per tablet, and 6 ringgit per tablet, and maximum dose. Usually we prescribe up to 6 tablet a day. You imagine 6 tablet is like 6 ringgit per tablet. It's so expensive. So we routinely, definitely, is a common practice in Malaysia. Still calcium carbonate as a phosphate binder. Until we see that the signal towards the high trend of calcium, only then we mix in combination the calcium and also lanthanum of Sevelamer, just to save cost as well.
Yeah, we do that too.
Yeah.
And then actually now the good thing or bad thing is we have generic
Yes.
Sevelamer coming in. Yeah.
I'm not
Yeah,
promoting,
yeah, Dr. Reddy's company. Yeah. Calciummimetic.
Yeah.
Yeah, that will be half the price, but still expensive.
It is because if you are using 6 tablet per day, even though it's 3 ringgit per tablet, then it's become 18 ringgit per day. Yeah.
Okay. There is a question, Prof.
Yeah.
Okay. How do we adjust activated vitamin D dose clinically in CKD or end-stage renal failure? Do we need to routinely monitor the vitamin D level?
Okay, so out of surprise, I don't think many lab can monitor the vitamin D level, especially the activated one. Towards my understanding, it's very difficult for you to monitor the activated vitamin D. The one that we do is not activated vitamin D. We didn't do vitamin D level in end-stage patients or CKD patients. Yeah, so basically what we do is we depending on parathyroid hormone, we check in end-stage every 3 months. The parathyroid hormone, then we adjust the vitamin D according to the parathyroid hormone. For example, the one that I mentioned just now, it's times 9 or 10 upper normal limit normal. So it's about 45, 50, depending on what you need to use. So we start the vitamin D at that particular time, and you didn't repeat it frequently. It's 3 monthly blood test. 3 months later or 6 months later, you see the parathyroid hormone. So if let's say it's coming down, you're happy with current treatment. If it's elevated, you increase the vitamin D accordingly. Yeah.
Yeah, there's a lot of limiting factor of optimizing the vitamin D treatment in our patients, mainly because of the calcium and the phosphate level.
Definitely, yes, agree with you, because like I've mentioned earlier, it gives rise to hypocalcemia. So that's something that you monitor as well. Yeah.
Okay. What about, would you like to share your experience with us on the management of these patients with calciflexis, UA?
Okay, so very interesting. I think as of now, one of my nephrologists compiling all the data in Malaysia, how to manage this UA. Of course, when they come very bad ulcers already, because it's late identifications, and of course you need to treat the infection aggressively. So what based on the literature, what's we have so far is still sodium thiosulfate intravenously, being given after dialysis each time. And how long you want to give is totally depends, because that's in order to reduce the inflammations, to reduce further damage to the vessels. That is why we give sodium thiosulfate. At the same time, you need to aggressively control the calcium and phosphate and refer the patients for parathyroidectomy. Based on our experience, I can say that 50% of patients pass away because of the complications, especially the infective wound. But half of them, yes, they are survived. Interestingly, one new therapy is basically towards rheopharesis. This is pretty new. I don't think this is kind of worldwide recognized it so far. It's basically a really new technology in order to improve calciflexis. It's similar like plasmapheresis, but this is to remove all the toxins related to the calciflexis, what we call rheopharesis. We have only one patient on it, and so far the wound heals kind of gradually improving, and this patient still surviving. So I don't have much bullet in managing calciflexis. It's important to control the infections, the wound not get infected, good wound dressing, and at the same time, make sure this patient dialyzed adequately. If this patient's on peritoneal dialysis, I will convert to hemodialysis, aggressive, bring down the calcium as well as the phosphate, including the parathyroidectomy. The sodium thiosulfate, it depends. If the wound is getting better, you can stop the treatment. If not, you keep continuing this sodium thiosulfate.
Okay. Yeah, there's a very difficult condition to treat actually.
Yes, yeah.
Mortality is, yeah, agree you, is very high.
Yeah, it's
There's one last question for you, Prof, before we end today. This is on osteoporosis. What is the choice of treatment of osteoporosis in end-stage renal failure?
Yeah, I must say that this been not really under-recognized. We hardly investigate this patient for osteoporosis, because you know that in dialysis patient, it's pretty hard for you to differentiate between this is a consequences of CKD, MBD, and osteoporosis. And even though you diagnose osteoporosis, end up you can't give anything because of the EGFR limit. Yeah. What do you think, Dr. Liu?
Yeah, it's very limited because of the GFR. So far, I have actually talked to my endocrinologist. They really have nothing very specific to offer because of the EGFR.
And we are not also, we also not really looking hard to look for the bone scan in our patients, right, Dr. Liu? So
there are so many other issues.
We didn't routinely scan the patient as well, so we
don't.
We didn't recognize, because we know that the limitation is the treatment. Even though you recognize this is osteoporosis, I bet you it's difficult to recognize because they have concomitant CKD MBD. So it's very difficult to diagnose these patients. And even though you diagnose it, you can't treat it.
Honestly, ideally, a bone biopsy might be helpful in a lot of cases. Except that, we don't have this. I think mainly the pathologists have. We don't have this specialty to look into that at the moment. I think it is 4:05. Yeah, thank you very much, Prof, for today's talk.
Thank you, Dr. Liu, and thank you, the team.
So thank you, everybody, for coming.
Thank you, Prof. Maisara, and thank you, Dr. Liu, for this very enlightening session today. So I would like to thank the audience for joining us in today's session. This is our QR code to be scanned for CPD points. And thank you all once again for joining us.
Thank you. Bye.
Yeah, thank you. Okay, bye.